in these difficult times. Today is June 5, 2020. I am Rifat Manan in Philadelphia, and I am remotely joined by my good friend Emilio Madrigal in Boston. Today, we are happy to welcome back Dr. Roberto Garcia for the second lecture of the Bone Pathology Lecture Series. Dr. Garcia is Associate Professor of Pathology at the Hospital for Special Surgery in New York. The title for today's talk is Cartilage Forming Tumors. As always, please feel free to post your questions and comments on both Facebook and YouTube chat windows, and Dr. Garcia will answer them towards the end of the session. Thank you, Dr. Garcia, for joining us today. Over to you now.
Thank you very much. Good morning, everyone. This is part 2 of our lecture series on bone tumors, and today we're going to be discussing cartilage-forming tumors, and we're also going to touch on notochordal tumors. I have no relevant financial relationships to disclose, and today we're going to be discussing benign and malignant cartilaginous tumors, which include the benign category. We have osteochondroma and multiple hereditary osteochondromas, Enchondromas and olease disease or enchondromatosis, Chondroblastoma and Chondromyxoid fibroma. The malignant category includes Chondrosarcoma and its variants, and we're going to talk about chordoma and benign notochordal cell tumor. So in the benign category, we start with osteochondroma, which is probably the most common, one of the most common benign tumors that we are going to see in general in surgical pathology. I remember that this was the first tumor I ever saw when I was in residency training. And this is an exophytic tumor that grows from the surface of the bone, composed of medullary and cortical bone, that has a very peculiar cartilaginous cap, and it usually projects from the surface of the metaphyseal portion of the long bones. It was for many years considered to be a malformative lesion, but recent studies have demonstrated that there are clonal chromosomal aberrations that are localized in the chondrocytes of the cartilaginous cap that suggest that these lesions may be neoplastic. There are two major genes involved in it, which are called EXT1 and EXT2, and these genes somewhat act as tumor suppressor genes. Interestingly, osteochondromas grow synchronously with the normal epiphyseal growth plate and usually stop growing when skeletal maturity is reached. That is when the growth plates close. So these two genes, EXT1 and EXT2, most of the mutations that we see are on EXT1. They encode for transmembrane glycosyl transferases that are named exostosin 1 and 2. And they catalyze the synthesis of heparan sulfate, which is a substance that has an important function in cell adhesion, growth factor signaling, and cell proliferation in the growth plate. Heparan sulfate somewhat exerts a negative feedback or an inhibitory effect on the proliferation of chondrocytes in the growth plate. And there is also interplay of Indian hedgehog and parathyroid hormone-related peptide, as well as fibroblast growth factor. And therefore, when there is this is a sort of like a inactivated mutation. So when the mutation occurs, the enzyme does not catalyze the production of heparan sulfate, so there is no inhibitory effect on the proliferation of chondrocytes, and there is a proliferative advantage for those chondrocytes. There's also other mechanisms of loss of polarity that lead to the growth of those chondrocytes sideways or away from the center of the bone. Osteochondromas are very common during the active growth phase. Like most bone tumors, they are remarkably most common in the second decade of life, and they're about twice as common in males than in females. Most common locations include the distal femur, proximal tibia, proximal humerus. They can also occur in the flat bones like the pelvis and the scapula, and less common in the axial skeleton. The tumors grow from the metaphysis of the long bone outwards, and there is a continuity of the cortex of the host bone with the cortex of the osteochondroma, as well as continuity of the medullary cavity of the osteochondroma with the parent bone. The cartilaginous cap usually is also covered by a fibrous periosteal band that becomes perichondrium on this particular surface. And you can see in the X-ray how smoothly the cortex of the bone blends with the cortex of the osteochondroma, as well as the medullary cavity. We can see the trabecular appearance of the cancellous bone inside the osteochondroma as it goes into the medullary cavity of the bone. Osteochondromas can be sessile or pedunculated, meaning that they have a stalk, and then many times the cartilaginous cap shows some degree of mineralization that can be seen on X-ray, but oftentimes you don't see it because remember, hyaline cartilage is completely radiolucent. A resected specimen from an osteochondroma, like we see here, this one is pedunculated. We can see that the medullary bone, it looks like normal cancellous bone with fatty marrow and probably some red marrow as well. And the cartilaginous cap usually is less than a centimeter. The average size is about 0.5 centimeters. It can be completely smooth, or on the outer side could be bosselated or multinodular, like we see here. So most of the sections that we take of interest are from the cartilaginous cap. CT and MRI can be helpful in the evaluation of osteochondroma. Especially in CT, you can demonstrate or actually confirm the communication between the medullary cavity of the tumor and the medullary cavity of the bone. And we can also see partly the cartilaginous cap, which is much better appreciated on MRI, especially in water sensitive sequences, because it appears bright due to the high water content of the extracellular matrix of cartilage. So this is often used to measure the thickness of the cartilaginous cap. The sections from osteochondroma histologically will show a hyaline cartilage cap that contains chondrocytes that many times disorganized, but they have an attempt at forming columns or arrange themselves into rows. And we can see here the little fibrous perichondrium, the layer of fibrous perichondrium that is on the surface. Beneath the cartilaginous cap, we see a recapitulation of what happens in the growth plate. There is endochondral ossification, which is replacement of cartilage matrix for bony matrix, and in a very highly vascular environment. This is very similar histologically to primary spongiosa, which is what you see in the growth plate. You will see chondrocytes that are somewhat arranged in columns. We see the cartilage that is becoming acellular because it becomes necrotic before it is sort of like resorbed by osteoclast or chondroclast and replaced by pink material, which is woven bone. Eventually, this bone will become lamellar. So it's exactly a recapitulation of what you see in the epiphyseal growth plate, and that is the characteristic feature of an osteochondroma. These are the chondrocytes that bear the EXT mutations. Osteochondromas are usually asymptomatic. They may become painful if they impinge on a nerve or a muscle, or they can fracture sometimes, and they only are treated when they're symptomatic or for cosmetic reasons. The recurrence of an osteochondroma is very rare. When it does occur, one should think of some complication, which is malignant transformation, which may occur in about 1% of the cases, maybe less, into what we know as secondary peripheral chondrosarcoma. Fortunately, these are low-grade lesions. The chondrosarcomas are mostly grade 1, the ones that occur in osteochondroma. There is a condition which is hereditary and is inherited in an autosomal dominant fashion, which is known as multiple hereditary osteochondromas. Popularly is referred to as multiple hereditary exostosis. This is a condition where there are multiple osteochondromas, which may occur in both the long bones as well as the flat bones, and they do cause defective metaphyseal remodeling with expansion of the metaphyses and asymmetrical growth retardation. So there will be some limb length discrepancies, as we can see in this patient. You can see multiple osteochondromas, some of which have been already resected. This is a closer view of that. This condition is also very much more common in males than in females, and it causes a lot of deformities. Usually manifests by adolescence and stops progressing in adulthood, similar to sporadic osteochondromas. EXT1 and 2 mutations are detected in about 90% of the cases of multiple hereditary osteochondromas. The main problem with them is that they have a higher risk for developing secondary chondrosarcoma than solitary osteochondromas is estimated to be approximately 5%. And that usually is seen when an osteochondroma shows some evidence of rapid growth associated with pain. Radiographically, it may show a higher degree of mineralization or calcification in the cap, and there might be some evidence sometimes of destruction of the bony stalk. But oftentimes that is not very easy to see. One thing that radiologically is evaluated is the thickness of the cartilaginous cap. So anytime that the cartilaginous cap appears thicker than 2 to 3 centimeters, it is worrisome for malignant progression or transformation into secondary peripheral chondrosarcoma. But again, fortunately, these lesions are low grade. So sometimes, very rarely, they can dedifferentiate, and that's when they may become a big problem. Enchondromas or central chondromas are benign cartilaginous neoplasms that occur inside the bone. About half of them will occur in the small bones of the hands and feet, and they're usually asymptomatic, but they may be associated with pain in the small phalangeal bones when they're small stress fractures. But as a general rule, when they occur in the large long bones, like in the femur, they are asymptomatic. This disease is almost exclusive of the appendicular skeleton. They're very rare in the axial skeleton, and usually occur in bones that are formed by endochondral ossification. About half of the cases have IDH1 and IDH2 gene mutations. These are isocitrate dehydrogenase mutations. These originally were describing gliomas and leukemia, but they are consistently seen in primary cartilaginous tumors of bone. And that includes specifically central chondromas, periosteal chondromas, classic chondrosarcomas, dedifferentiated chondrosarcoma, and also surface chondrosarcoma. As we go over these entities, I'm going to re-emphasize whether they are positive for these gene mutations. The treatment of enchondromas, because they're benign and they have a low recurrence rate, is usually by curettage. As I said, about half of them will occur in the small bones of the hands and feet, but they also may occur in the metaphyseal portion of the long bones, like the proximal and distal femur, the proximal humerus, also small bones of the feet, and the ribs as well. The age distribution is pretty broad. They occur mostly through the third, fourth, fifth decades of life, and less common at the both ends of the lifespan, and they're equally distributed between males and females. Radiographically, enchondromas have a very peculiar characteristic of showing flocculent or popcorn-like calcifications, and also a pattern that is known as rings and arcs. So if you look carefully, you may see some little circles or rings and sometimes arcs that are seen, and that represents mineralization and ossification at the periphery of the cartilaginous lobules of an enchondroma. It is important to mention that enchondromas are very benign lesions. They do not show progressive growth. So usually the surrounding cortices and the surrounding bone will have very little changes, if any. It is accepted to have a little bit of endosteal scalloping on the endosteal surface, which we don't see here specifically, but you should not see any major changes around it, because if you do, it means that the tumor is behaving aggressively. If you see closer, you can see some of the little rings and arches in here and some of the flocculent popcorn-like calcifications. That is because the tumor is composed of lobules of hypocellular hyaline cartilage, which may show some mineralization in the center of the lobule, but at the periphery you may see some endochondral ossification. The cells are chondrocytes that reside within lacunae, and they have very small, uniform, pycnotic, and hyperchromatic nuclei. On CT, we can see better here the rings and arcs pattern, and that correlates with the fact that there is peripheral endochondral ossification around the lobules of hyaline cartilage. Here's some area of central mineralization. This will look a little bit like a fluffy or powdery type of calcification, and then the peripheral endochondral ossification will appear as an arc. On MRI, cartilaginous lesions in general will have a very bright appearance due to the high water content of the extracellular matrix of cartilage, and that is on water-sensitive sequences. Enchondromas do not permeate or entrap pre-existing cancellous bones. So you will always see the bone at the periphery of the lobule, but you will never see a fragment of bone in the center of the lobule. So that is because they have a slow growth and they allow for the surrounding bone to become resorbed. But it will never permeate or entrap the pre-existing cancellous bone. And you can see also that there's some endochondral ossification at the periphery. Marrow elements are often seen in mixed up together with samples of Enchondroma. In the small bones of the hands and feet, they may produce major changes because these are very delicate bones. So some degree of expansion and scalloping can be allowed. And also the lesions in these locations will have a more cellular and myxoid appearance. So we are a little bit more tolerant in terms of cellularity and myxoid changes in small lesions from the small bones of the hands and feet. And these are features that otherwise in a large bone like the femur would be a little bit alarming. In general, when there is pain in the absence of a fracture, or there is radiological evidence of cortical destruction, or, these are features that are suggestive of malignancy in an otherwise intramedullary cartilaginous tumor. Sometimes chondromas occur on the surface of the bone, and in this particular instance, they produce a large indentation with a very smooth contour and some degree of sclerosis, which we refer to as saucerization, and there's also some buttressing at both ends of the periosteal surface. These lesions do not invade the medullary cavity, so they will remain on the cortex, as we can see here histologically. The cortex, even though it's somewhat indented, it is not breached, and the cartilaginous lobule of the lesion is sitting right here. So there's no permeation into the medullary cavity of the underlying bone. Periosteal chondromas are composed of lobules of hyaline cartilage, which may be a little bit more cellular than what you see in the intramedullary counterparts, and they are covered by the periosteum. So these are lesions that are rising underneath the periosteum. Here's one of the edges where we can see how the periosteum is lifted on and covering the lobules of hyaline cartilage. The cortex underneath becomes a little bit sclerotic, but is never breached. And these lesions are positive for isocytosine dehydrogenase mutations. There is a syndrome of multiple enchondromas that is known as Olliers disease. This is a rare, non-hereditary disorder characterized by multiple intraosseous cartilaginous tumors. They do lead to significant deformities in bone as well as in the retardation of the growth. And you can see that sometimes the bones that are involved by enchondromatosis are shortened and deformed. We have multiple tumors, not only in the metaphysis, but also on the diaphysis of these patients. In the hands, they can produce significant expansion and deformities of the involved bones. The disease usually rarely progresses after puberty, which is an interesting finding. The degree of cellularity atypia that I see microscopically in these lesions is higher than conventional or enchondromas. So as pathologists, it is important for us to know that the lesion that we're looking at comes from a patient with OLH disease, because otherwise we will be alarmed and probably suggest that the possibility of malignancy. So again, we're a little tolerant about cellularity and atypia in the lesions that come from OLH disease. About 90% of the lesions have isocitrate dehydrogenase mutation. Here's another patient with, we can see the calcifications. From moderate, and we also can see myxoid change. That is that the chondrocytes are no longer within lacunae, but they begin to turn spindle and stellate shape. Myxoid change, as a general rule, when extensive, is suggestive of malignancy in cartilaginous tumors, but it is more tolerated in patients with OLH disease. A big problem with these patients is that about half of them, up to half of them, may develop a secondary chondrosarcoma, which is usually manifested by pain and an enlarging mass and local destruction. It is very difficult to establish this diagnosis histologically alone. So careful clinical radiological correlation is required in order to establish a diagnosis of malignant transformation in OLH disease. Fortunately, most of the lesions are low-grade chondrosarcomas, but again, the differentiated chondrosarcoma can occur, and less frequently transformation into an osteosarcoma. Like we mentioned before, enchondromatosis with soft tissue hemangiomas is known as Maffucci syndrome. We see here multiple intramedullary tumors and then multiple phlebolytes or calcified calculi within the vascular tumors, which are hemangiomas that could be of cavernous type or spindle cell type. The patients with Maffucci syndrome are susceptible to developing malignancies like chondrosarcoma, fibrosarcoma, angiosarcoma, and osteosarcoma, but also they can develop carcinomas and glioma. So this is a very difficult situation because these patients have almost like a sentence to die from malignancy of some kind. Patients that have widespread disease appear to be at higher risk than those who have localized disease. Moving on to other benign cartilaginous tumors, we go to chondroblastoma, which is a lesion of immature cartilaginous cells, hence the name chondroblastoma. These cells usually are mixed with osteoclast giant cells, and there's very little, if any, hyaline cartilage formation in these lesions. Chondroblastomas commonly present with mild pain, but many times they could be asymptomatic. Radiographically, they are very characteristic because they are usually well-demarcated lesions that occur, or sometimes are confined, most of the times are confined to the epiphysis of a long bone, usually in a patient with an open growth plate. So this is a lesion of young patients. Sometimes they may move a little bit into the metaphysis, but most of the times they are confined to the epiphysis. These lesions are benign, but they may produce, in about 2% of the cases, clinically indolent metastases to the lungs that usually remain stationary. They do not tend to progress. Sometimes they can involute. Chondroblastoma is a lesion of young age, so remarkably more common in the second decade of life, children, adolescents. It may be seen in young adults as well. It is more common in males, and their distribution is usually the epiphysis of the proximal tibia or distal femur, followed by proximal humerus, proximal femur. In the skull, they can be seen in the temporal bone, and sometimes are seen in very unusual bones like the talus, calcaneus, and the patella, as we can see here. The lesions, as we mentioned before, are lytic, circumscribed, confined to the epiphysis. On CT scan, we can see that they look completely lytic and well circumscribed. And on MRI, we can see that they may show heterogeneous intermediate signal on T1 and bright signal on T2, which is a characteristic feature of cartilage lesions. Here we see a case of chondroblastoma. This one in particular has significant perilesional sclerosis and is very well circumscribed. Chondroblastomas are composed of cells that have a very polygonal appearance with well-demarcated cell borders and brightly eosinophilic cytoplasm. Chondroid matrix is not abundant. Usually when seen is focal, and there might be variable degrees of mineralization or calcification. One peculiar characteristic is calcification of the chondroid matrix, which does it in a linear fashion around individual chondrocytes. This is the pattern that we know as chicken wire pattern of mineralization. And you may see variable numbers. Here's the lesion on MRI. One important thing to mention is that IDH1 and 2 mutations are absent in chondroblastoma. So this makes them different from the classic cartilaginous tumors of bone. Like I mentioned before, chondroid matrix is usually focal, we can see it here, and at times it appears just like a highly nice eosinophilic material. The cells have very well demarcated cell borders, and they impart the lesion sort of like a cobblestone appearance. The nuclei may have some longitudinal grooves that will make the cells look a little bit like coffee beans. And there are, like I said, variable numbers of osteoclast-type giant cells, which are completely benign, but sometimes may make the differential diagnosis a little bit complicated with other giant cell-containing lesions, especially giant cell tumor, which is also a lesion that occurs at the end of the bone, like chondroblastoma. And here's a closer view of the so-called chicken wire pattern of mineralization, where you can see chondroid matrix becoming mineralized in a linear fashion around individual chondrocytes, which sometimes undergo apoptosis or necrosis. The nuclei of the chondroblast may have a coffee bean appearance. You may see nuclear grooves or sometimes nuclear pseudo-inclusions. And these cells may be positive for a great variety of markers. S100 may be one of them, but it's not always expressed. They may be positive for keratins as well, P63, caltonin, V240, and interestingly, DOG1 for some time it was proposed to be a good marker for chondroblastoma, but not all of them will express it. This is a marker for GIST. But lately, it has been discovered that chondroblastomas have a mutation for a histone-related protein, H3F3B in particular, which is seen in approximately 90% of the cases. And this mutation can be detected immunohistochemically by a marker called K36M, which will stain the nuclei of the chondroblasts very strongly and crisply positive. You can see that the giant cells are negative, and this has become a tremendous weapon for us in the diagnosis of chondroblastomas, because in small biopsies, the differential diagnosis is broad and mostly relies on clinical radiological correlation. The main differential diagnosis will include giant cell tumor and clear cell chondrosarcoma, which are the other two lesions that tend to occur in the epiphysis or arising at the end of the bone. But both of these lesions are lesions of mature individuals, whereas chondroblastomas do occur in children and adolescents. But not all the tumors read the books and follow the rules, so there will be challenging cases where it will be necessary to go to a strict clinical radiological correlation, as well as the use of some molecular techniques. In this particular case, K36M may be useful in the differential diagnosis. Unfortunately, there have been some overlap. Some giant cell tumors may be positive, as well as clear cell chondrosarcoma. There has been one case that has been reported to be positive. So again, clinical radiological correlation still stands. Curettage and bone grafting is the treatment for chondroblastomas, and the recurrence rate is approximately 15%. There are rare chondroblastomas that may show locally aggressive behavior. They're referred to as aggressive chondroblastomas, and they have really no specific histopathological features that would suggest aggressive behavior. The chondroblastomas have very little, if any, cytological atypia, and you may see an occasional mitotic figure, but they usually are not very mitotically active. Moving on to another benign cartilaginous tumor, we have Chondromyxoid fibroma. This is a tumor that is composed of lobules or spindle stella-shaped cells that are embedded in abundant myxoid chondroid matrix, and it has a very, very peculiar nodular appearance, each nodule being separated by fibrous tissue, hence the name Chondromyxoid, and the fibrous bands are the fibroma component of the lesion. In the fibrous bands, you will see spindle cells and as well as some multinucleated osteoclast-type giant cells. These lesions usually occur radiographically sitting in the metaphysis of the long bones, and they usually are eccentric, and they have a very peculiar scallop and sclerotic margins. Very little, if any, abnormalities of the cortical component of the bone. Pain is the most common presenting symptom, and it's usually mild. And chondromyxoid fibroma may be seen arising on the surface of the bone, what we call a periosteal chondromyxoid fibroma or surface chondromyxoid fibroma. The lesions are more common in the third decade of life, but they can be seen in younger individuals as well as in older ones. They almost have an equal gender distribution, and they're remarkably more common in the proximal tibia. They can also affect the fibula, the small bones of the feet, as well as the pelvis and the radius. Chondromyxoid fibroma has a very peculiar histomorphology, and that is of stellate-shaped spindle cells that have a dense eosinophilic cytoplasm, and they are embedded in abundant myxoid matrix. There are condensations of cellular tissue at the periphery that compose the fibrous bands that surround the lobules of chondromyxoid material. Here's one example where we can see the scallop margins, and there's a little bit of endosteal scalloping on this proximal ulnar lesion. It shows practically no mineralization. That is very commonly seen in chondromyxoid fibromas, and on MRI they can appear as a low grade on T1 and bright signal on water sensitive sequences. A core biopsy from this specimen, this case, it was very informative because we could see very clearly the fibrosepta dividing the lesion into lobules and containing osteoclast-type giant cells within them. And the cells have a very spindle to cell-shaped appearance in abundant myxoid matrix, with some areas showing some degree of hyalinization. The cells of chondromyxoid fibroma tend to be positive. They may be positive for S100, but they tend to be positive for smooth muscle acting. And then specifically in the septa, they're more of a myofibroblastic type of phenotype. They can be positive for SOX9, and they may show certain degree of cytological atypia to a point that sometimes can be worrisome, and in a small biopsy may be suggestive of Chondrosarcoma, which is the main differential diagnosis. But the lobulation of the lesion and the radiographic appearance usually is very reassuring that it is not a Chondrosarcoma. IDH1 and 2 mutations are absent in chondromyxoid fibroma, and that helps us distinguish them from Chondrosarcoma. Rearrangements of glutamate receptor 1 or GRM1 have been reported recently in about 90% of the cases of chondromyxoid fibroma. Unfortunately, at this point, there's no commercially available antibody for GRM1, but they can be done with gene sequencing, and it can be very helpful in confirming the diagnosis. But in very difficult cases where chondrosarcoma may be in the main differential diagnosis, isocitrate dehydrogenase mutations will be absent in chondromyxoid fibroma and positive in chondrosarcoma. Treatment is with curettage because the lesions have a very good prognosis and are completely benign, and recurrence rate is similar to chondroblastoma, between 10 and 15% of the cases. Chondrosarcomas are malignant cartilaginous tumors that where the neoplastic cells produce cartilage matrix, not bone, with the exception of one of the subtypes, and we're going to see that in a while. This is the second most common primary malignancy of bone after osteosarcoma, and they may be primary or secondary when they arise in a pre-existing lesion like an enchondroma or osteochondroma, especially in the syndrome of enchondromatosis and multiple osteo. Their location may be inside the bone, central, peripheral when they occur outside, specifically on an osteochondroma, or juxtacortical, which are referred to a periosteal chondrosarcoma. And the special variants include dedifferentiated, mesenchymal, and clear cell types. Chondrosarcomas, like all cartilaginous tumors, show evidence of flocculent calcifications with ring and arc pattern, but different from benign lesions, they usually do cause significant changes in the surrounding bone, with often seeing endosteal scalloping, and at times you may see some degree of thickening of the associated cortices. Chondrosarcomas are lesions of older age, so contrary to osteosarcoma, which tends to occur in the first few decades of life, chondrosarcomas are lesions of patients older than 40, and the peak incidence is actually after age 50. They're 1.5 times more common in males, and they are also lesions that occur more in a proximal location. Osteosarcomas tend to occur usually in these areas of rapid growth, like in distal femur, proximal tibia, but chondrosarcomas tend to occur most often in the pelvic bones, proximal femur, proximal humerus, scapula, and of course they can be sometimes seen in the axial skeleton, the ribs being also very commonly involved. Here we see an example of chondrosarcoma where you can see the irregular calcified matrix inside the bone, but notice how thick and irregularly scalloped the surrounding cortex is. This means that the lesion inside has aggressive behavior. And on MRI, like all cartilaginous lesions, chondrosarcomas will appear very bright on water-sensitive sequences like T2. Chondrosarcomas tend to occupy large segments of the bone, and eventually they break through the cortex and extend into the soft tissue. There are two histological features that are important in the diagnosis, and one is permeative growth, like we mentioned something like that in osteosarcoma as well. That is, that the tumor grows very fast in the intertrabecular spaces, occupying every single spot in the where the fatty marrow should be sitting. This is permeative growth. And second will be entrapment of pre-existing bone. You can see these fragments of bone, many of which are viable. They still have nuclei inside, and they show this very ragged appearance because they're being partially resorbed, but definitely entrapped inside the bone. These are features of malignancy histologically and should not be tolerated in any benign lesion. So these are diagnostic of chondrosarcoma. Here's a closer view of an entrapped fragment of bone with still viable osteocytes within their lacunae. And we can see that the degree of cellularity may vary from low to intermediate to high, depending on the grade of the lesion. Abundant, highly cartilage matrix. Nuclei within chondrocytes usually are hyperchromatic, but then they may begin to open up a little bit when we see internal structure of the nucleus, and many times nucleoli. This is what is considered to be a chondrocyte atypia. Chondrosarcomas have no specific gene abnormalities or chromosomal abnormalities, I'm sorry, but they do have mutations of IDH1 and 2 in about 60% of primary chondrosarcomas and about almost 90% of secondary chondrosarcomas. So this is important and it may be helpful diagnostically. Here we have more permeative growth pattern and eventually cortical breakthrough extension into the soft tissue. This is what chondrosarcomas do. They essentially disseminate widely in the medullary cavity and eventually through endosteal scalloping and permeation, they invade into the soft tissue. Here's one example of a chondrosarcoma that really remained confined to the epiphysis and a little bit into the diaphysis, and it has a little bit of a sclerotic margin and not a lot of mineralization inside. This particular lesion will almost look like a chondroblastoma radiographically and clinically. The patient was relatively young, but on biopsy it proved to be a chondrosarcoma grade 2. We can see this is a moderately cellular tumor with some mild degree of atypia and abundant myxoid matrix. These chondrocytes are no longer present within lacunar spaces. So when you see a lot of myxoid change in cartilaginous lesions, that is in favor of a grade 2 chondrosarcoma over a grade 1. Here's another example of widely infiltrative tumor with this hiling appearance. Chalky white calcifications, foci of hemorrhage and necrosis may be seen as well. And notice how much endosteal scalloping and erosions are seen by the tumor into the surrounding cortex. Entrapment of pre-existing bone, extensive myxoid change. Chondrocytes not within lacuna anymore, but actually looking spindle to stellate shape. And in some instances in the biopsy, you may see consider that this could be chondromyxoid fibroma. But if you look at the X-ray, you will be able to tell the difference. And this is to give you a closer view of chondrocyte atypia, when you can see internal structure of the nucleus, open chromatin with nucleoli. That is chondrocyte atypia. Depending on the degree of cellularity, atypia, and mitotic activity, we can classify chondrosarcomas into grade 1, low cellularity with very pyknotic hyperchromatic nuclei. Only entrapment of pre-existing bone will tell us that this is a grade 1 chondrosarcoma over an enchondroma. So they are indistinguishable and they require careful radiological correlation. Grade 2 chondrosarcomas have moderate cellularity, moderate degree of cell or nuclear atypia, and often they contain myxoid areas. And finally, grade 3 chondrosarcomas have frank nuclear anaplasia. In many cases, some begin to spindle out. So sometimes they look a little bit unlike classic cartilaginous tumor, and you can see often mitotic figures and necrosis. Chondrosarcoma metastasized to the lungs, followed by skin and soft tissue, and the treatment is en bloc excision. They have very poor response to chemotherapy. The tumor location is important in order to accomplish a complete resection. It is not the same to have a pelvic chondrosarcoma than to have a chondrosarcoma in the distal femur. So the location of the tumor will impact the prognosis as well, because on that depends the resectability of the tumor. Now, curettage with intraoperative adjuvant in the form of cryotherapy or liquid nitrogen has been used in grade 1 chondrosarcoma that is confined to the medullary canal. So it is, even though not the most appropriate technique, but it is very widely used. Because grade 1 chondrosarcomas, at the most, what they will do is recur locally, and they have little, if any, metastatic potential. So the prognosis will depend not only on the location and the stage, but also the histological grade. It is very important for us as pathologists to establish a grade. And grade 3 chondrosarcomas will have an almost 70% metastatic rate. Grade 2 chondrosarcomas, almost 1/3 of them will metastasize, and grade 1 chondrosarcomas will metastasize in less than 10% of the cases, much less. However, low-grade chondrosarcomas can dedifferentiate in about 15% of the cases, so that is a problem that is always lurking. The main differential diagnosis in chondrosarcoma will be first, how to distinguish an enchondroma from a grade 1 chondrosarcoma. This is sometimes very difficult. Again, you rest on the clinical and radiographic correlation when there's evidence of aggressive behavior like endosteal scalloping or in some areas cortical breakthrough and invasion into soft tissues. These are all indicative of malignancy. Histologically, if we see entrapment of pre-existing bone, this is supporting a diagnosis of chondrosarcoma over an enchondroma. And the other major differential will be with the chondroblastic osteosarcoma. But in a way, this might be a little bit easier because chondroblastic osteosarcoma is a tumor of younger individuals. I don't mean to say that chondrosarcomas cannot occur in younger individuals, but they are uncommon. And they are usually characterized by the presence of woven bone, even though sometimes you can't see it in a biopsy. In very difficult cases where the differential cannot be established alone on in a clinical radiologic correlation, IDH1 and 2 mutational analysis may be helpful because these, if it is a chondrosarcoma, it will be positive. And if it is a chondroblastic osteosarcoma, it will be negative. There is a periosteal variant of chondrosarcoma. These lesions occur on the surface of the bone. They're usually larger than periosteal chondromas, but like their benign counterparts, they do not invade the medullary cavity of the host bone. They usually are larger than 5 cm, and there may be evidence of invasion into the surrounding soft tissue. Histologically, the lesions cause some focal destructive changes at the base, but they do not permeate into the underlying bone. They have a moderate degree of cytological atypia. They usually are grade 1 to 2 tumors, and they do show IDH1 and 2 mutations. Here's another example, surface chondrosarcoma, and we can see how the medullary cavity is not invaded by the tumor, but there's some degree of soft tissue invasion. Special types of chondrosarcoma include dedifferentiated chondrosarcoma, which is a biphasic tumor composed of a low-grade cartilaginous component represented here by the calcified area, next to a high-grade non-cartilaginous component, which is here in the big lytic lesion that we have right next to it. The dedifferentiated non-cartilaginous component can be in the morphology of an undifferentiated pleomorphic sarcoma, fibrosarcoma, osteosarcoma, angiosarcoma, rhabdomyosarcoma, and lately even squamous cell carcinoma has been described arising in a pre-existing cartilaginous tumor or say squamous dedifferentiation. The transition between the two components of the tumor is usually sharp and abrupt, as is seen here radiographically. You will see it histologically as well. And most cases occur in older age groups. Most cases that we see in practice are patients all in their 60s and 70s. And there is frequent pathological fracture and associated soft tissue mass with evidence of rapid growth. Like I mentioned before, there is an abrupt transition between the two components of the lesion. The cartilage component is usually low to intermediate grade, and the non-cartilaginous component is usually a high-grade spindle to pleomorphic cell sarcoma. There are mutations of IDH1 and IDH2 in about 90% of the cases in both components, and this is an advantage because if you get a biopsy only from the differentiated component, if you do a mutational analysis for IDH1 or 2, you can establish the diagnosis. But most of the times, this is established on clinical radiological correlation and also on histology, given the characteristic features of the tumor. Here's another one where you see the cartilaginous component here calcified right next to a very big shadow, and there is a pathological fracture associated to it. So the cartilaginous component usually shows areas of with appearance of hyaline cartilage with focal mineralization, and right next to it you see a very fleshy mass, which is a dedifferentiated component. And there's an abrupt transition. If you take the section from here, you will see that there is a very sharp demarcation between the low-grade cartilaginous tumor. Here we have a little bit of entrapment of pre-existing bone and the dedifferentiated component. A major challenge is when the dedifferentiated component is an osteosarcoma. Here we see anaplastic spindle cells with woven bone formation. If you get a biopsy from here, you will feel compelled to call this an osteosarcoma, high grade. But if you do establish clinical and radiological correlation, you will see that this is an older patient, in which an osteosarcoma will be much less common, and you will see that this is a biphasic tumor. So even if you don't have the cartilage present in the biopsy, you will be able to see that there is a mineralized lesion inside. So this is very helpful. In the worst of the case scenarios, you can always resort to IDH1 and 2 mutational analysis. And if this osteosarcoma that you see in the biopsy is positive, then it comes from a dedifferentiated chondrosarcoma. We have another one here where the cartilaginous tumor is in the diaphysis with a mineralization, and then all of this here is the dedifferentiated component with endosteal scalloping, and essentially looks like a non-mineralized tumor. Low-grade cartilage, intermediate cell grade cartilage is always seen in the dedifferentiated chondrosarcoma. It's never going to be high grade. However, the dedifferentiated component is remarkably high grade with lots of mitosis. You can see necrosis and marked nuclear atypia. The main differential diagnosis will include mesenchymal chondrosarcoma, which we're going to discuss next, and is a biphasic cartilaginous tumor that contains a non-cartilaginous component that is composed of small round blue cells. Chondroblastic osteosarcoma will be characterized by tumor osteoid, higher grade cartilage. That is important because the cartilage that you see in osteosarcoma is high grade, not low grade like what you see in the differentiated chondrosarcoma. And in the worst case scenarios, IDH1 or IDH1 and 2 mutations will be helpful in making the differential diagnosis. Unfortunately, the prognosis of these tumors is very poor. About 90% of the patients die within 2 years of disseminated disease, and chemotherapy and radiation have not shown to improve prognosis. Sometimes they're given as palliative care, but they're not really very helpful. Mesenchymal chondrosarcoma is a dimorphic cartilaginous tumor where the non-cartilaginous component is like a primitive mesenchyme. So it's composed of very small round blue cells or spindle cells, and the cartilaginous component is typically low grade, just like the differentiated chondrosarcoma. One difference is that the two components are usually intermingled with one another. There's really no sharp transition between the two. This is a lesion that usually occurs in younger individuals, even younger than the classic chondrosarcoma or the differentiated chondrosarcoma, second, third, and fourth decades of life. It has no sex predilection, and it can be seen in the head and neck, maxilla, mandible, and even the meninges. It can involve also the ribs, vertebra, pelvis, and femur. And it can also be exoskeletal. It's probably the only true chondrosarcoma that can occur in the soft tissue, because classic chondrosarcoma does not occur in the soft tissue. Radiographically, it presents a cytolytic lesion with some degree of calcification, but nothing specific about it. And oftentimes, you can see that the lesion is very destructive. It invades into the soft tissue. It may have some degree of mineralization, but it will be hard to distinguish this between a chondrosarcoma or maybe an osteosarcoma. So there's really nothing specific about the radiographic appearance of a mesenchymal chondrosarcoma. Here's another case, coincidentally also in the mid-shaft of the bone, but they can be seen in the metaphysis as well. And there's some stipple calcification inside. This is the resection specimen. It has the appearance of glistening cartilage, but there's some degree of mineralization here and some areas that look a little bit fleshy. The characteristic feature is low-grade cartilage intermingled with small round blue cells or spindle cells. Like I mentioned before, there is no sharp transition or between the two components. They are mixed with one another. And classically, it is described that many cases will have tachyon-like dilated vessels or hemangiopericytoma-like vessels, which when seen can sometimes help to put it together in the differential. Again, low-grade cartilage, round blue cells, very cellular appearing, and immature appearing tissue. This is one case of exoskeletal mesenchymal chondrosarcoma of soft tissue. It is a large tumor wrapping around the femur without invasion, and on the specimen showed a lot of mineralization inside. Here's the gross specimen. Actually, this is the um, femoral vein, which was invaded partially by the tumor, and the histomorphology was that of a classic mesenchymal chondrosarcoma. Low-grade cartilage, small round blue cells. By immunohistochemistry, the small round blue cells are positive for CD99. The cartilage is not, and on the contrary, S100 is positive in the cartilage and negative in the round blue cells. These round blue cells are negative for FLI1, negative for EWSR1, and more importantly, there is a specific gene fusion that is found in mesenchymal chondrosarcoma, which is diagnostic. It's a HEY1-NCOA2 fusion, and that is now diagnostic of this tumor because it has not been detected in any other tumor. EWSR1 and IDH1 and 2 mutations are absent in mesenchymal chondrosarcoma, which helps in the differential diagnosis with other conditions. So for Ewing sarcoma, no EWSR1 rearrangement. For dedifferentiated chondrosarcoma, the non-cartilaginous component will be high grade, and they will have IDH1 and 2 mutations. And for small cell osteosarcoma, usually you see neoplastic osteoid and not really cartilage. The treatment of mesenchymal chondrosarcoma will be radical surgery combined with chemo and or radiotherapy. This in particular does not have a very significant effectiveness. It's still a matter of debate on whether chemo radiation will have some impact on survival. And the prognosis of the tumor is in general poor, with late recurrences and metastasis mainly to the lungs, bones, viscera, and lymph nodes. The third subtype of chondrosarcoma is clear cell chondrosarcoma. This is the third tumor that tends to occur in the epiphysis of the lung bones. The proximal humerus is one of the most common locations. The tumors usually appear as well circumscribed. They will with intact cortices, and they may have some variable degrees of mineralization. This particular one doesn't show much. So the giant cell tumor and chondroblastoma always enter the differential. Chondroblastoma may be excluded due to the age of the patient because these tumors tend to occur usually in the third and fourth decades of life, more common in males. And radiographically, like I said, they were well circumscribed with focal calcification, an intact cortex. Sometimes they may show significant mineralization, which will bring into consideration that it is a chondrosarcoma, but because of the location, you have to think of clear cell first. They also may occur in the spine, and they may involve the vertebral bodies. And the cells have a very peculiar, abundant clear cytoplasm, and they are usually admixed with multinucleated osteoclastite giant cells, and they may have little struts of woven bone. And that is probably the only subtype of chondrosarcoma where woven bone is allowed. These cells are strongly positive for S100. They definitely have features of chondroblastic differentiation. They may be positive for SOX9 as well. And we can see here again that when there is chondroid matrix, it's usually very focal. What you see is definitely little irregular trabeculi of woven bone. And you can see here how the cells have vesicular nuclei with prominent nucleoli. They usually are not very anaplastic looking, so atypia is probably up to moderate, and you may see occasional mitosis, but not a lot of them. Here's one clear cell area with chondroid matrix formation. So you can even see sometimes classic chondrosarcoma associated to a clear cell. Importantly, they are negative for IDH1 and 2 mutations. Chondroblastomas and giant cell tumors have to be ruled out, and this one in particular, based on the morphology, is very easy to exclude giant cell tumor. And chondroblastoma may probably enter the differential if you see an area that has some chondroid matrix formation, but the clear appearance of the cytoplasm of the cells will be helpful in distinguishing it. And in worst case scenario, K36M cannot really be helpful because one case has been reported to be positive. So in this particular case, I don't think molecular would be very helpful. Now, one important differential diagnosis will be a metastatic clear cell carcinoma. And to make matters worse, these tumors can sometimes express keratin, but they are very strongly positive for S100, which most clear cell carcinomas are not. So S100 probably will be the best weapon to confirm clear cell chondrosarcoma versus metastatic clear cell carcinoma. These are low-grade tumors with metastatic potential, and they have an overall mortality rate of about 15%. Finally, we're going to talk about notochordal cell tumors and chordoma. Chordoma is a malignant tumor of notochordal differentiation. They tend to occur in the axial skeleton. Classically, they're seen in the sacrum, but they can also occur in the spheno-occipital region. And these tumors are very destructive, very aggressive, but they are slow-growing tumors. Because of this location makes the diagnosis usually late, because symptoms will occur when the tumors are advanced. In the spheno-occipital region, they may be detectable earlier, and that's probably why they have a certain better prognosis. But they can also occur anywhere in the spine, and there are extra-axial forms. So the distribution is more common in the sacropoccipital region, the spine, and the spheno-occipital region. Chordomas are tumors of older age, so most of them occur in patients in their 50s, even though they can occur sometimes in younger patients, and they're twice as common in males than in females. They are destructive lesions. Sometimes in X-rays are not very well visualized, except for the absent components of the destroyed bone. But when you do CTs and MRIs, then you can see very clearly that the lesion has broken outside of the distal sacrum and usually invades into the soft tissue, pushing against the pelvic organs. This is a resection specimen of chordoma. Chordomas are very hemorrhagic and necrotic tumors with a lot of myxoid appearance. And usually at the time of diagnosis, they have already broken through the cortex into the surrounding soft tissue. The histology of chordoma is basically a lobulated tissue with abundant mucoid or myxoid matrix. The cells have abundant eosinophilic cytoplasm, and they usually are arranged in cords and ribbons, and sometimes into nests. If you look closer, the cells will have a multivacuolated cytoplasm, and in many instances, they will have a permeative growth pattern. So you will see invasion of the intertrabecular spaces with entrapment of pre-existing bone. Abundant mucoid matrix in the form of pools of mucin. There may be abundant hemorrhage, ribbons, or interconnecting rows of eosinophilic cells with bubbly cytoplasm. The characteristic cell of chordoma is a physalliferous cell, which is a cell with multiple vacuoles that may indent the nucleus. Sometimes may be similar to a lipoblast in another setting. And usually cytological atypia is not very significant. Mitosis may be seen, but they're usually not that abundant, even though rarely you can see some poorly differentiated forms that may have a higher degree of cytological atypia. The immunohistochemical profile of chordoma, for many years, these tumors were diagnosed based on a combination of vimentin, S100, and cytokeratin. But now we have brachyury, which is a transcription factor of notochordal development that is positive in chordomas, and it has become a tremendous powerful tool for the diagnosis of chordoma. This is brachyury with a very clean and strong expression in the nucleus of chordoma. So the differential diagnosis includes metastatic mucinous adenocarcinoma, myxoid chondrosarcoma, myxopapillary ependymoma. These are all lesions that may occur in this location. And fortunately, now with brachyury, we can solve that problem very easily because the other two lesions are negative. Complete excision is the treatment of choice, but it's seldom possible, especially due to the location of the tumor. Adjuvant radiotherapy is used in incomplete resections, which often happens. The prognosis is that of a high rate of recurrence with metastasis occurring to the bone, lungs, skin, and lymph nodes. Rarely, dedifferentiation may occur into a high-grade sarcoma. And eventually the patients will succumb to the disease after multiple local recurrences. There is a variant called Chordoma where there is some degree of cartilaginous differentiation, which occurs in younger individuals and has a much better prognosis. And also what is known as a extraaxial chordoma, Parachordoma or Chordoma periphericum, which are tumors that occur outside of the axial skeleton in bone or soft tissue. Many of these lesions were actually reclassified as myoepitheliomas, but the ones that are truly positive are positive for brachyury. So there are still lesions that are diagnosed as extraaxial chordomas. And the last thing we want to touch base about is the so-called benign notochordal cell tumor. These are lesions that are completely benign. They usually are asymptomatic and discovered incidentally, even though sometimes they can be painful. And they usually present as an area of sclerosis inside the vertebral body. They can occur throughout the spine in any location. Usually with very little, if any, abnormality of the bone. There's no cortical breakthrough, there's no aggressive features. The lesion is very well circumscribed and usually only a few centimeters in size. Histologically, these lesions have the appearance of univacuolated cells that look like adipocytes, even though they're often admixed with other cells that have pale eosinophilic cytoplasm. But it's very easy to confuse this with fatty marrow, especially because you have intermixed marrow elements as well. One characteristic feature of the lesion is that instead of producing destructive growth, like you see in chordoma, is that on the contrary, they permeate, but they do not destroy the bone. They incite some degree of sclerosis, which can be seen here. There is a thickening of the trabeculi, and that's why they appear sclerotic on radiological images. One good trick that is used histologically is cytokeratin stain, because these areas will be stained positive for cytokeratin, and that is very helpful in the differential diagnosis when you confront one of these cases. But nowadays the management is just follow-up, so very rarely you will encounter one, but just wanted to bring this to your attention because there is a controversy on whether these lesions might be precursors of chordoma. We have seen them basically occur adjacent to a classic destructive chordoma. You may see areas that look like a benign notochordal cell tumor, but there's still no studies that demonstrate progression of one benign notochordal cell tumor into chordoma. With that, we finish our lecture for today. I'm leaving my email for questions in case I don't have enough time to respond. Questions that will show up, but now we're open for any questions that may have been sent. Thank you.
Thank you, Dr. Garcia, for this excellent discussion. And I can see a few questions. So the first question is from Malini. The question is it possible to distinguish between grade 1 chondrosarcoma and Enchondroma in small biopsy in the absence of bony tissue? How do we sign out these cases? Is there an intermediate category?
Okay. The histologically alone is impossible to establish a differential unless you're lucky enough to find an area of bone entrapment within the biopsy. The problem is that these biopsies a lot of times are obtained either in the form of a curated material, less likely people would do a core biopsy or something like this, but occasionally it can happen. But the problem is that there might be some intermixing of components iatrogenically, so you cannot really rely on that. It's definitely established on radiological grounds. In my particular case scenario, I can see something that looks like essentially a low-grade cartilaginous lesion. But when I go to the X-ray, if I see that there's significant thickening or scalloping of the cortical bone around it, or any evidence of cortical breakthrough or erosion, then I would have to basically favor a low-grade chondrosarcoma. Most of the times, the term that I use is low-grade cartilaginous lesion. And then in a comment, I discuss the findings. But in some cases, you can also use the term atypical cartilaginous neoplasm, and then also in a comment explain the findings on the X-ray. But to be honest with you, it is not possible to distinguish them on histological grounds alone.
Thank you. The next question is from Kalyani. Do you use the term atypical cartilaginous tumor for grade 1 chondrosarcoma of appendicular skeleton?
Well, to be honest with you, I prefer to use the term low-grade cartilaginous tumor because when you, in a way, they're synonyms to one another, because what you're telling them exactly is that you're not 100% sure that it is frankly malignant. But at least if you say that the lesion is low grade, you are reassuring the clinician that they can go ahead and either curette the lesion and treat it as a grade 1, because on the long run, if it is an enchondroma or a grade 1 chondrosarcoma, it's not going to matter much. They have to follow the patient closely after they curette the entire lesion completely. The problem is when the lesion is more than just grade 1. So I rather use the term low-grade cartilaginous neoplasm, see comment, than use the term atypical cartilaginous lesion. But in a way, they both mean the same. They mean that the lesion is not high grade, which is what the surgeon wants to know. Because if it is high grade, then the treatment is different.
So here is another question. Can we see mitosis in chondroblastomas?
Yes, but very rarely. I mean, they're not really very common to see. It's not very common to see mitosis. But if you see mitosis, it doesn't really make a difference. What you don't see is atypical ones. There's definitely no atypical mitosis.
Next question is from Emmanuel. Do periosteal chondrosarcoma arise from periosteal chondromas?
To be honest with you, I have not seen that happen. I don't think it has been documented. I guess, most of the periosteal chondrosarcomas that are diagnosed are chondrosarcomas from the beginning. But no, I have not seen that happen.
So Zenith wants to know if the surgical treatment plan is same for different variants of chondrosarcomas.
Well, high-grade chondrosarcoma, mesenchymal chondrosarcoma, and dedifferentiated chondrosarcoma probably require complete resection. So what you want to do is just remove the entire tumor. Local control is what is going to dictate the prognosis. Only the low-grade tumors are treated more conservatively. So the main thing is that high-grade chondrosarcomas there's no adjuvant for them. So chemotherapy is going to do nothing to them. So it's all going to depend on the resection. Now, for the mesenchymal and the dedifferentiated, there are some centers, some institutions that use palliative adjuvant therapy, but there's still no definitive knowledge of how effective these palliative or adjuvant therapies are. Clear cell on the other side, on the other hand, can be treated a little bit more conservatively because it's a low-grade cartilage tumor. Complete resection, not really with curettage. Curettage is not appropriate for, so it's not treated like a low-grade classic chondrosarcoma, but it's sort of like more like an intermediate grade tumor.
Right. Next question from Kalangitan. I hope I can pronounce the name properly. Sorry if I'm not. How do you differentiate mesenchymal chondrosarcoma from a sarcoma with chondrites elements, especially if it is extraskeletal?
I think that one of the first things that I think the sarcoma with chondrite elements that I have seen so far is an extraskeletal osteosarcoma. It also had bone in it. But the one thing that I probably would think about is the small cells. They will express CD99. That's one. They're small, round, very primitive looking cells. Usually other sarcomas with chondroid elements will be more high grade. And in the case scenario where I am not 100% sure and I need to have a definitive answer, I will probably send it for genetic testing and try to find the gene fusion. A1NCOA2 is definitely the way to go to confirm this diagnosis.
Right. I think one last question. So this is from Hussam. How to differentiate extraskeletal from skeletal mesenchymal chondrosarcoma based on histology?
No, there's no way to tell them apart. Well, it's basically on imaging, because extraskeletal ones are completely in the soft tissue. A problem might be when there is secondary involvement of the bone, where you can say, okay, is the tumor coming out of the bone into the soft tissue or vice versa? Many times this happens not only with mesenchymal chondrosarcoma, but many other tumors in general. But I think that on histology, you can't really tell. They're identical.
And we have quite a lot more questions, but I think for lack of time, we will not be able to answer them here. But as Dr. Garcia mentioned, please feel free to write an email to him, and he would be more than happy to answer your questions. And thank you all our viewers for listening in, and thank you, Dr. Garcia, for your excellent talk, and which is definitely very helpful for all of us. You would be really happy to hear that you had several hundred viewers from at least 30 different countries that I could take note of, including viewers from as far as Lithuania, Cambodia, Myanmar, Tanzania, Nepal, El Salvador, to name a few. And a special shout out to Vilma from El Salvador. Thanks for joining, and thanks to all our viewers for joining in. And as always, if you like our lectures, please follow and like our Facebook page, that is Patcast, and also YouTube channel, and subscribe to the YouTube channels. And if you subscribe to our newsletter, you would stay tuned and informed about the upcoming lectures. And Dr. Garcia's next lecture is also coming up. That would be next month on miscellaneous bone tumors. Stay tuned. So our next podcast is on Tuesday, that is June 9th. That would be a very interesting talk. Dr. Neil Teese from New York, who is a very renowned liver pathologist, he would be online, and he would be discussing a very interesting topic, that is the interstitium of the human body. And that's a very interesting talk that's coming up, and stay tuned and let's hear from Dr. Teese as he discusses this interesting concept about the role of human interstitium in our human tissues. So hope to see you all again, and thank you again, Dr. Garcia, for joining us today.